Focused on localized prostate cancer, advances in treatment. It's obviously a huge spectrum, and we only have time to touch on a few pieces of that, but again, there are a lot of clinicians here that you can ask questions about. So our first speaker in this next session is Dr. Dan Lin, who's an internationally recognized urologist focusing on the prevention and treatment of prostate cancer with a particular interest in this idea of active surveillance. So, Dan?
Perfect, thanks. Well, thanks, Pete, and it's really nice to see everybody here today. This is our fourth annual conference here, and I'm just happy to see everybody come out for this. So, as Pete said, I treat patients along the spectrum of prostate cancer, so that might be patients that have higher risk prostate cancer. I do robotic prostatectomy as well as open and other urologic malignancies. And then what we're going to focus on this morning is very early prostate cancer. So again, amongst the whole spectrum of prostate cancer, this is prostate cancer that we've traditionally thought of as the turtle on the block, and I think that's not my nomenclature, but probably attributed mostly to Paul Lang in this setting, is the turtle on the block cancer that might never harm a patient. And so, again, out of all the prostate cancer we diagnosed in the year 2015, that might be as many as half the cancers are these turtles on the block that might never need to be treated. And of course, there's a whole other half, if not more, of the prostate cancers that we do feel benefit from treatment. So this first part of this session will be focused on the slower ones, the sort of the snails or the turtles that we see that we diagnose. And we do something called prostate cancer active surveillance, and I think that I presented this before in past years. We clearly know that the safety of active surveillance is established. There are now worldwide guidelines that place active surveillance as a standard of care option, as just one option. And I'll show you that in a coming slide. And the question is who to do this on. So I said the turtle on the block, which is an easy image of a little turtle barely creeping along. And we call this low-risk prostate cancer. So this would be the low-risk group by various different groups, or maybe even very low risk. And what does that really mean? I'll show you that on the next slide. And maybe even prostate cancers that seem to be maybe a little bit more aggressive. So who are the low-risk prostate cancers? Well, typically this is who they are. For those of you in the room, you might recognize the stage just as what we examine with our digital exam. A PSA of less than 10 and a low Gleason score. These are the turtles that we think the low-risk group of prostate cancer. But then there are the very low risk, and you can see here listed on the slide. I won't go through all of them. There are various similar aspects. This is PSA density. This is how many cores from the biopsy might have cancer and so forth. We think this is very low risk. And is it really very low risk? Well, these are the sort of the blunt criteria. And I'll show you, Dr. Chang showed you the Nccn guidelines. That's the National Comprehensive Cancer Network. We're one of this network, so all the major cancer centers. We're the only NCI-designated cancer center in the Northwest for the many-state region. And we all sit on a committee called the Nccn Committee. And the Nccn puts out guidelines for all different varieties of malignancies every year, and this is the one that just came out in 2015. So this is the NCCN Cancer Guidelines, and they say very low risk here. You can see many different criteria. I would say that some of us don't even calculate PSA density. Many take less than the number of cores, and they put this in this group. But if you look here, and I could walk you through the next two slides, this is expectant patient survival. So if a man is expected to live more than 20 years or 10 to 20 years, you can see for very low risk, down here it might say do active surveillance. Whereas up here, a longer life expectancy, really it's balanced between active surveillance, radiation, or surgery. I think that, again, this very low-risk criteria is not really followed by many, so what the NCCN did was just lump it all together and say, just low risk. You just have, if you just qualify based on these criteria over here, low risk right here, which most, at least half of the prostate cancer that I'll diagnose this year is low-risk prostate cancer, probably 50%. Maybe not quite 50. But when you look here, a man, and most men fall in this greater than 10-year life expectancy, what really surprises me still is that we lump the initial therapies into one of three choices, and they're all equal. There's not one that's really superior recommended over the other. One is active surveillance, which we'll talk about. The other is radiation or prostatectomy, and active surveillance involves biopsies. And you can see here they say get a PSA, repeat a biopsy about once a year, maybe not quite once a year. But then you have this balanced against radical therapies, and we know that these radical therapies do have side effects, which we can't get into for sake of time. And what's amazing to me is that, and Dr. Gore showed this a little bit, these are all balanced options, so they're equal. There's not one that the NCCN is recommending over the other, but clearly 80% or more, perhaps 90% are choosing the radical therapies. And is that reasonable or not? We'll get into some of that right now, actually. There are major questions, and I'll spend about 2 minutes on each of these major questions and then end, and we can do question and answer. But are these criteria for entry accurate? Are biopsies really necessary? Biopsies, as Dr. Gore was saying, have risks. A corollary to that, are there alternative methods to determine whether we should have a man on active surveillance? And the last big one is, can we alter prostate cancer behavior even after the diagnosis for the turtles on the block? And we'll get into just one slide of that as well. And it really plays in to the strengths in the first session with Dr. Newhouser at Stanford and others, showing what they do and whether we can really affect prostate cancer behavior. To do this, I'll show results from one of our trials, the trial that I lead, and we lead here at the Fred Hutch. It started as somewhat of a West Coast effort funded by a foundation called the Canary Foundation based in the Bay Area. And then over time, it's really spread across the nation as 9 different sites with central pathology. And we have about 1,200 patients that are enrolled in this prostate cancer active surveillance trial, where men that choose active surveillance are entered in this trial, and the big focus of this is biomarkers, and here's how it works. If they have prostate cancer diagnosis, they choose active surveillance, they have serial exams, serial biopsies, we collect all sorts of specimens. If there's something we call pathologic reclassification, which means that they seemingly have a little bit worse prostate cancer, some of them choose to get primary treatment, some of them choose just to continue active surveillance, even if the cancer looks like it's getting worse. If there's no pathologic reclassification, many still get primary treatment, others choose to continue, and then of course we have long-term follow-up. We're all about biomarkers. The point of this slide is we get blood, serum, urine, DNA on all our patients and are following them quite extensively, and I'm filling up freezers here at the Fred Hutch at a frightening rate and drawing the ire of the administrators. But you see here we're getting a lot of specimens, and we're going to make some great discoveries, I think. I really do think we're on the cusp of many great discoveries, and I'll show you that in a minute. When one looks at all the different sites we have, they're all fed in the Fred Hutch here, and then we collaborate with third parties as well as industry. We have a very big pipeline with industry, and I think that's very important to align public and NIH dollars with industry dollars and really make some progress. So what does it mean to be progression on active surveillance? Well, we really consider it to be just something in the biopsy. Any increase in the tumor grade, so it goes from that Gleason 6 to a Gleason 7. Maybe there's 1 core out of 12 goes to 3 or 4 or 5 cores. That's really what we consider progression. Now, others talk about maybe something like a digital rectal examination being worse, or maybe even PSA going up. We really collect that data, but we don't use it because it hasn't really been proven to be of great benefit after the diagnosis for these particular patients. And I'll just show you just 1 or 2 slides. This is where we are currently, again, almost 1,200 patients. We follow them for about 3 years. We're still getting them, so there are some patients that have been on for 6, 7, 8 years, but we have a median of about 3 years. About a third of them have been reclassified. In other words, their cancer looks a little worse. About 250 have had treatment. So again, not all men that the prostate cancer looks a little worse are actually going on to treatment. And of these 250, some of them actually have worse cancer. And I think as opposed to, I had all these flow charts in here, but I think as opposed to doing that, let's just cut to the chase. If you take 100 men and they're the turtle on the block, and we follow them all, and we say we're going to do biopsies every year or 2 and get your PSAs, all the blue ones are going to still stay in active surveillance after 3 years. Their cancer does not appear any worse, and or if it does, they say, I just want active surveillance. The ones that are in red are getting treated, and the ones there that are unfortunately in the dark figures, they're treated and they actually do look like they have pretty aggressive pathology. But if you really look at that, that's 100 people, and there are 6 of them that seemingly could have, and they've never had recurrence. None of them have died of prostate cancer. Nobody in our 1,200 men have died of prostate cancer. And again, these are select groups, so these are the group of men that we think are the turtles on the block. But this gives you an idea of the safety of active surveillance. But can we do better? And I think that this gets to the next is, can we do better? Well, we can. We actually just published this month and European urology, where we have a risk calculator and one can plug in, and again, I won't do the whole exercise, but many men come to me and say, do I need the biopsy? Do we really need the biopsy? And here is a calculator where we can plug in the age, the month since the last biopsy, what their PSA is, how many cores were positive, how many positive biopsies, and so forth. And it can just spit out a pie chart, and it will say, the chances of a man having progression or increased grade of cancers, in this case 14%. The risk of no cancer on the biopsy, like the biopsy finds no cancer, is right here is 41%. That doesn't mean the man doesn't have cancer. That means that it was just missed by the biopsy. And then there's about a 45% chance of having the same Gleason 6 disease. And you can see here, does this man need a biopsy? Well, that's in the eye of the physician and the patient. So we have actually a biopsy risk calculator now. We've also, as I said, aligned with industry, and we're looking at new biomarkers. And one of them is this biomarker called Prolaris. You might have heard about it. It's based on the biopsy tissue. It's something called cell cycle. And they've had many different publications showing that this biomarker, if you do it on tissue, predicts prostate cancer death or recurrent prostate cancer. It helps decision making. And I'll show you how that works. And again, not to get too much in the weeds, but I want you to focus over here. This down here, just focus down here. This is the chance of recurrence. Okay, so what we're really talking about are these guys. That after treatment, the chance of recurrence is probably only 10 or 15%, which is pretty good. That means 90% or 85% of the time they're cured, we think, by just what we know about their Gleason grade, about them, about their age. But if we use this test, you can see, so we know that their risk of recurrence is somewhere in 10 to 15%. But if we use this test, we can actually find the dot that they are. And we could actually say, well, it looks like you're 10%, but if we do this test, you could be 30% chance. So this test does stratify this much different than this much. And I think that it's an interesting test, and we're using this one quite a bit. There's another test called Oncotype DX. You might have heard about this. They have a breast cancer test. They're based in the Bay Area. This is a similar, you send the tissue, they look at the genes. So we look at it under the microscope and we see Gleason grade. They look at it under the DNA microscope and see different genes that are up and down. And their endpoint is different. Their endpoint is whether if you took a man's prostate out, he'd actually have bad prostate cancer. And again, I'll show you a very similar representation. Just focus down here. Actually, focus over here first. Focusing over here, if you look at these guys here, let me just go back. If you look at these two little dots here, I can say to a man, based on clinical values, that his chance of having bad pathology is somewhere between 10 to 15%, right here, these two dots. But if I do this test, I can really put them along this line. I can say that as opposed to just being somewhere around 10 or 15%, I can really stratify you amongst this whole line. So I think it's a very important test. The last one that we're looking at is something called 4K score. The 4K score is 4 different calicities. Now, PSA is one of them. It's been used as an algorithm. I'll show you that in the next slide. It really improves the diagnosis of prostate cancer. So we use this in men that have had negative biopsies maybe, and it is appearing to be very useful. And what it does is this. It takes your various circulating calicities, and one of them is PSA. So total PSA measures all these little products here. There's PSA, there's something called NIC PSA, Pro PSA, HK2, complex PSA. And what it does is it combines them all into an algorithm, all these 4 calicities. It adds in additional clinical information, and then it spits out a score, and that score is really associated with high-risk disease, high-grade disease. And so we're using this along with others. So it is my belief that we have a blunt instrument. We say, you have prostate cancer, you can have active surveillance, which is basically nothing, or radical treatment. And again, I find it very surprising to say that I show this slide to my patients all the time. They say, Dr. Lin, what do you think I should do for my prostate cancer? And I say, this is what the nation and the world thinks you should do. Let's go through why one is better than the other or not. I think that hopefully at one of these days, and this is 2015, mind you, that we're going to get to 2018 and we are going to have some sort of a biomarker score. That's the hope. The low biomarker score, you stay on active surveillance. If it's medium, you have a choice. If it's a high biomarker score, you go on for radical therapy. And I think that we're working that way. I put here 2018. I'm very hopeful that it's earlier. But right now, I think that's a pretty conservative estimate that we won't get there until then, at least with our work. So the last couple of minutes, I want to talk about future studies, and this plays into a little bit of what you heard before. I think that we're very, very involved, certainly in the biomarkers and what you can find in the blood or DNA, and we've worked with Dr. Stanford and others who have a great platform and infrastructure for doing these studies. And we're interested in other things. How about lifestyle dietary modifications? How about hormonal manipulations? How about complementary medications? And of course, if we can do these in the men that are on active surveillance, and then you repeat biopsies, imaging, other molecular diagnostics, we're really going to find, I think, some insight in the disease behavior, of course, looking at all the tissue and blood. And I will put a plug in, I think Dr. Newhouser mentioned this before. This is an NIH-funded study that we're very proud of one of our young investigators, Jonathan Wright, having, and again, men with active surveillance that might have a slightly higher BMI, the body mass index. And they will be randomized to either a healthy lifestyle intervention, it's part of a diabetes prevention program if there's exercise and nutrition, versus basically just standard recommendations as opposed to a very intensive lifestyle change. And then there's various endpoints, and we, I think, are going to find some ways to manipulate the behavior of prostate cancer in this way. This is just, again, a little bit of a plug for what we are doing. This, grant funding is really the currency of research, I think. At least one of them, the federal dollars, of course, we rely on philanthropic efforts quite a bit, but these are some of the federal dollars which we've received for various efforts. And again, I think that you'll hear about this later. We're into the precision medicine approach and a personalized approach to prostate cancer. So the take-home points for you, and I think that entry criteria for active surveillance are generally well established. There's a high rate of adherence in our group. There are these emerging biomarkers in industry which we find very promising. We have many potential interventions, some of them being diet and lifestyle. And then I think the overarching challenge really is to find out which cancers are indolent, which cancers are aggressive, and lower the burden of what we call overtreatment, while also identifying men who actually need treatment right away. So I'll end here and just put my past team. Thank you.
Wonderful. Write your questions down. You're going to have a chance to ask. I'm sure there'll be plenty. So back for return engagement, Dr. Gore is going to be talking about side effects of treatment.
I apologize for my prevalence on the roster today. So quality of life. Quality of life is something we get a number of questions about. And a lot of what I'm going to present is stuff that is not new to a lot of you. And a lot of you have had some profound input that has influenced the direction of some of what we're doing here locally. And this is going to show you how we're taking some of that local work and broadening it really to a national and international effort. So why are these patient-reported outcomes, why are they important? Well, they're important because what we think, what we perceive as the physician is just simply wrong. What you see here is you see in green what the patient says is a problem, and in blue what the doctor says is their patient's problem. And you can see that it's exactly. Doctors woefully underestimate their patient's problems with incontinence, woefully underestimate their patient's problems with urinary frequency and sexual dysfunction. So this concept of patient-reported outcomes is really critical. It's not enough for me to just say, well, this is how I think you're doing based on what you told me in that 5-minute clinic visit. It's really important to understand how you're doing, in your own voice. And so we measure patient-reported outcomes using both function, so this sort of objective measure of how you're doing, as well as bother, which is your perception of the distress you feel as a result of your urination, your sexual function, your bowel function, things like that. And we try to measure how you're doing in general, your overall health, as well as some more maybe prostate cancer specific domains like urinary function, sexual function, and bowel function. And we have a number of surveys that we use to do it. There was a recent international consortium of health outcomes experts that selected one of these tools, but in general there are a number of ways that we can measure how you're doing from a quality of life standpoint. And there are a number of registries that in the 90s started saying, well, gosh, we need to clarify from the patient's perspective how people do after prostate cancer treatment. And a couple of these are listed here. There's CAPTURE, which combines community data with academic centers, with VA centers. There's the prostate cancer outcome study that Dr. Stanford was heavily and continues to be heavily involved in, that took a population-based sample of men with prostate cancer and tracked them from the mid-90s and recently published, and I'll show you this, their 15-year outcomes. There's an update to this called CSER, which took a new sample of men with prostate cancer just a couple of years ago and is looking at maybe the quality of life impact of some of these newer treatments for prostate cancer. And then there's also a multi-center effort that only focused on academic centers. And so what have we learned from these? What have we learned from these large clinical registries that looked at patient-reported outcomes about how they're doing with respect to their prostate cancer treatment? Well, if we look at the blue line here, that's surgery. So we know that urinary control, or your ability to hold your urine, appears to be worse after surgery than it is after radiation treatment. And this is just to show you that a higher score on this curve is better. That sexual function appears to be similarly affected by all of the treatments. So anyone that tells you that your sexual function will not be impacted by prostate cancer treatment is not correct. Bowel function typically is not robustly disturbed by prostate cancer treatment. And the prostate cancer outcome study echoed a lot of these findings. So those results were up through 10 years. These results are up through 15 years. And you can see that just like CAPTURE, continence is better after radiation than it is after surgery. Sexual function, so better is higher. Sexual function is impacted irrespective of the treatment that you have. And bowel function outcomes appear to be better than urinary and sexual function outcomes after prostate cancer treatment. We did our own work, and what we did was we tried to look at the probability that you would return to your baseline quality of life. And that kind of echoes a question that patients ask us, which is, well, how am I going to do compared to how I was before treatment? So these curves try to echo that. How are you going to do compared with how you were before treatment? So this is your likelihood of returning to your baseline urinary control. And you can see it's pretty good after radiation. It's not quite as good after surgery. If after 2.5 years you still have unsatisfactory urinary control, it's unlikely to continue to get better. So after a couple years, you should start thinking about whether you should pursue secondary interventions for your urinary control. Sexual function, this is return to baseline. So this is your likelihood of returning to your baseline sexual function is pretty profoundly impacted after all of the typical treatments for prostate cancer, whereas bowel function isn't. Oftentimes people return to their baseline bowel function after prostate cancer treatment. Now that's one end of the spectrum. That's sort of objectively how you're doing. This is how bothered you are by your symptoms. And this is what kind of comes across our doorstep. This is when you come to us and say, I'm really distressed about blank. And so this shows you that after surgery and radiation, that urinary bother tends to be actually higher after some of the radiation treatments than the other treatments. This is brachytherapy in red. And higher after surgery early, but by the time people are a year out and more, the level of distress people experience is similar across all three treatments: external radiation, brachytherapy, and surgery. So there was a high-level evidence review that gathered up all of this quality of life data for the previous decade and came to a couple conclusions. Number one, bowel problems tend to be uncommon, but if they are going to happen, they're more likely with radiation. Urinary control problems, urinary incontinence, are much more common after surgery to remove the prostate. And sexual function problems appear to be common after all of the different treatments for prostate cancer. Now, we translated these quality of life outcomes into this concept of decision aids. And so one way in which we can try to reduce the side effects of prostate cancer treatment is to better match you with the treatment that you're going to receive. And so what I mean by that is everyone comes into this process, this prostate cancer diagnosis, with their own values and preferences for how they want their life to be led. And that can influence which treatment is best matched for you. So the Agency for Healthcare Research and Quality, and you can find this online. It's a little bit of a long URL. But it gives you information, right? It collects your values and preferences, and then it delivers unto you some coaching for how you can communicate with your prostate cancer provider. And a number of decision aids, like the AHRQ decision aid, have looked at how these decision aids can help men newly diagnosed with prostate cancer. And in general, they help men make a better decision. So they take away some of that uncertainty and conflict that you experience when confronted with a new prostate cancer diagnosis. And they do some things like increase your satisfaction with your role in your decision, increase your ability to navigate your own uncertainty, things like that. So this concept of decision aids is important. But where decision aids somewhat suffer is in the individualization of a prostate cancer diagnosis. And this is trying to put sort of a mathematical spin on it. But the reality is giving you some stock content like, continence is better after radiation, bowel function problems are better after surgery, things like that. It ignores the fact that everyone has a very variable trajectory after prostate cancer. So this is showing 300 men who had prostate cancer surgery and had perfect continence before their operation. After their surgery, within the first 2 months after surgery, their outcomes were all over the map. So you can see 300 different lines going all over the place. If we just look at the top quartile, the people that had the best urinary control early after surgery, they tend to continue to do well through 4 years after treatment. So if a man comes and sees me 6 weeks after their prostatectomy and they already have good control, I can counsel them that they are likely to maintain it. But if they don't, if they are in this bottom quartile, their trajectory is all over the map. And so this idea of sort of stock content decision aids, while they appear to be helpful, they ignore sort of the individual trajectory that men go through as they experience prostate cancer treatment. And the reality is, this is an emerging concern that we can now address, right? We have tablets, we have smartphones, we have ways to get your information, your patient-generated data that we didn't have before. But we also have graphic software, we have better computing software so that we can take that information and do cooler things with it than we could even 10 years ago. And this is sort of the design concept that emerged from a lot of the foundational work that we did, as far back as 2010, 2009 when I first got here. And this is our kind of design concept of QOL tracker that takes these patient-centered questions that many of you contributed, like, how am I doing compared to how I was before treatment? So that tells us that it's important to look at your longitudinal trajectory. How am I doing compared to other men? How can I compare apples to apples instead of apples to oranges? So some sort of normative score. So how can I compare me to men like me? And this idea that I want to be able to generate expectations for the future. So how am I doing now, but can I expect to get better, get worse, or sort of stay the same? And part of that relies on patient matching. So some of the sort of under-the-hood work that we're doing is we're working with biostatisticians to try to model these individual patient trajectories. And we're learning that with some specificity, we're going to be able to match men to men like them to create your own individual expected trajectory. And that work is being synthesized and promulgated by Movember, actually. And so I will have to grow a mustache in perpetuity. I will never be able to get away from growing a mustache. But Movember is investing a lot of money. I don't look good with a mustache. Many of you look good with a mustache, but I don't. So that's particularly painful to my impressive vanity. Movember is investing a lot of money in survivorship care. And so survivorship care, that's the concept that, a new cancer diagnosis is daunting, it's scary, you either feel like you need to have some active treatment or you go on to active surveillance, but you've emerged from that initial diagnosis and treatment phase, and now you're dealing with the after effects of treatment. That's survivorship. And so we have several interventions that we're moving forward with in this Movember program. Self-management, helping men make decisions about either their newly diagnosed prostate cancer or later on in their prostate cancer trajectory when it's come back potentially, social support, sexual health recovery, and sort of overall wellness, sort of a lifestyle changes that are important to prostate cancer care. And we're leading up here at the University of Washington the self-management portal. So this integrates a lot of the work that we've done with our design concept of QOL tracker with the possibility of broadening these efforts to a large audience at 15 research sites and a web-based platform that is going to allow us to collect patient information, distribute to you a feedback report of how you're doing contextualized with the outcomes of other men like you, and then based on how you're doing and the bother or distress that you experience as a result of how you're doing, output to you self-management content to help you with these detriments. So what's unique about prostate cancer is if you have a problem with urinary control, if you have a problem with sexual dysfunction, there are treatments for that. Now, you may not be getting offered some of those treatments, but we have these secondary therapies available to help with some of these dysfunctions. Some of them may be behavioral, like Kegel exercises, but trying to target self-management strategies based on your own individual outcomes is one of the primary goals of what we're going to be doing in Movember. This is a slide that I've been showing a lot recently, and it's just trying to highlight the value of patient-generated data. So I saw a talk by a mathematician that was very impactful to me about putting your milk crate on the internet. And what he means by that is, we all in college generated a lot of intellectual content. I wrote a bunch of essays about whatever Shakespeare play I had to read, and that intellectual content gets stored in a basement collecting dust, whereas actually that content has value. Just like your individual patient-generated data has value. That value is not currently being harnessed. So there's a website called Patients Like Me that tries to collect patient-reported outcomes from patients with rarer cancers. And so these graphs show outcomes of patients with Lou Gehrig's disease, ALS. And what they found was that a lot of patients were using off-label lithium to do anything they could to stave off the really horrible progression of that disease. And they were able to take patient-generated data to do high-level comparative effectiveness research to show that this off-label use of lithium didn't actually make a difference in their ALS trajectory. So that's taking patient-generated data, not from a clinical trial, through naturally collected sort of milk crate data and doing high-level research with it that we can learn a lot from. And so I think that is maybe a tall goal, but something that we can aspire to. So importantly, treatment has side effects. Prostate cancer treatment has side effects. Anyone that tells you otherwise is not being truthful with you. There are ways to create decision support aids that help you navigate this decision-making process and make it easier for you and better match your treatment with your own personal values and preferences. But our hope is that with these new biomedical informatics interventions, we can try to create tailored just like we talk about personalized medicine using genetics, genomics, personalized medicine using your values and preferences and your own personal outcomes to improve the survivorship care for men with prostate cancer. I will put in one quick plug, that those of you in the audience have had a lot of input in the direction of this program, and that's input that we're going to continue to solicit. So if anything on these slides, impacts you or drives you to want to be involved, please don't hesitate to send me an email. Thank you very much.
Thank you. So the last talk in this session before we go to the Q&A is Nola Klemfus, who's a manager of our Act Smart program, which is the IPCR 6-part plan to reduce the impact of prostate cancer and eventually lead to a cure. So this really extends on from Dr. Gore's work, and Nola's going to describe this new nascent project called Empower.
Thank you, everyone. I am so excited to give you guys a preview of our Empower project because it really